Perfect. So I was given this rather challenging talk to tell you a little bit more about meniscus root tears. And for me, that's a challenge in soccer players. So let me tell you a little bit more on this topic. Now, these are my disclosures. Now, before we go into the meniscus root as such, I think it's very important for you to understand how important the meniscus is. It has a number of functions. One of the main functions is, of course, load bearing. And as you can see here, when we would lose the meniscus on the lateral side, that would actually leave the cartilage with 80% more stress. And on the medial side, the meniscus covers about 60%. So if you lose these structures, that has major impact on the joint. Especially in load bearing, as you can see here, you need that meniscus, especially on the medial, but surely on the lateral side, to actually adapt the convex on convex situation on the lateral side and the convex on concave situation. So it has major implications. If you have a root tear, biomechanical studies have shown that that just is equal to a functional total meniscectomy. So that has a major situation where you get meniscus extrusion because of the loss of the root, and therefore you get really quick onset of osteoarthritis. And this is, for a soccer player, of course, a situation that you want to avoid, a functional total meniscectomy. The effects of the root tear itself is that you lose your meniscus, and you have peak stresses now on the cartilage, which degenerate rather quickly. If you have a load-bearing situation, you lost your meniscus, most of these patients, in a matter of time, and that can take 10 years, that can take 20 years, but once in a while, that just takes a year or 2 years, you're going to end up with an arthritic situation, bone on bone. And especially the soccer players with issues on the lateral side can end up with very quickly progressive lateral osteoarthritis. Not only on the load-bearing situation, the meniscus have a very important function, but also on the stability. And we are now more and more aware that the stability, or that the menisci are in fact very important secondary restraints in conjunction with the ACL. And that is a very new insight that we have nowadays. There's some very nice biomechanical data there. So on the medial side, if you have this situation, where actually the medial side is a medial ball in socket situation, and you would lose your meniscus, then you have a situation where if the ACL is ruptured or if your ACL is intact, you're going to have a switch and you're going to have more AP instability because of the lost meniscus. And again, in a root repair or a root tear on the medial side, that can have major implications. So it has major stabilizing role, both in Lachman and less in pivot shift. And this situation is clearly illustrated here, where you can see that this is the situation with the meniscus intact above. And this is below here, the situation where the meniscus is missing. You can see the increase of instability just because you lost the meniscus in conjunction with an ACL injury. And that has been nicely shown here in this biomechanical data. It's a little bit different on the lateral side because the lateral side is the mobility compartment. So on the lateral side, there is a loose link with the femoral condyle. And if you have your lateral meniscus lost or you had a root tear, then actually you're going to have an increase in the pivot shift maneuver. So the rotational instability will be significantly higher. And this is a situation with an intact meniscus. And then here below you have a situation with a destructed lateral meniscus. So you have a higher pivot shift, you have a higher rotational potential. On the lateral side, you have a higher AP instability on the medial side, depending on which side the meniscus is injured. Now, one advantage on the lateral side is that there's not only a big root here on the lateral side, but there's also once in a while a meniscus femoral ligament that connects that lateral meniscus to the femur, and therefore the root is of less importance. And that is a very good situation because you actually can compensate, the human body can compensate for lateral root tear because of the existence of these two very important ligaments that are present in a high number of our patients. If we're looking to the imaging of these things, medial roots and lateral roots, very obviously, if you look at these situations, the posterior medial meniscus root tear is characterized by medial extrusion, chondral damage, and ACL degeneration. So if you have a patient that comes in with a meniscus root tear, which you can see here, or with a phantom sign, so the meniscus is apparently not there, that is a very strong indication for medial posterior root tear, and you have extrusion of the meniscus. Very often these patients already will have some cartilage degeneration, and it causes secondary stress on the ACL, so the ACL might just start degenerating slowly. On the lateral root, the situation is a little bit different. On the lateral root, it is characterized by less extrusion, less chondral damage, but very often you will see these in conjunction with an acute ACL injury. So if you have an ACL injury, look for the lateral root because it might have been damaged during the situation, during the injury. This is MRI-wise. And if you look at both these populations, medial roots and lateral roots, and this is very nice recent data, it's not very clear yet, but this is all recent data, then you will see that the average age of your medial meniscus root patient is not your actual soccer player. Most of these patients will be above 52, around 52, so 29 to 71. So this is a more degenerative pathology in average, but once in a while we will see a posterior medial meniscus root tear in a soccer player, but these are older patients and they should be considered a more degenerative pathology. On the lateral side, it's pretty clear that these patients are younger and it is more a traumatic pathology, and that is very interesting to understand. So if you have a soccer player with a medial meniscus root tear, unless he describes a real clear trauma, sometimes you will have a more degenerative pathology. And recently I saw one coming in with a Bolac 10 degrees, so that's more degenerative pathology. Very interesting to understand that difference. Surgically, you can classify these in a number of classifications, and the essential bit is that these ones we can repair quite well because it's actually very close to the bone. If you have a situation where the tear at type 2 is a centimeter away from the root, then that healing potential will be very difficult, and if you have a very complex tear, it makes life even more complex. In the type 1s, you will see either complete ruptures or you will see incomplete ruptures. So that's very important to understand. And by the way, I want to thank Romain Zeil, professor in Luxembourg, who gave me a number of these slides. So there's a number of repair technologies out there, and all of this is just published in the last 5 years. There's a very increasing attention for medial meniscus root tears and the repair technology. While these lesions were out there all along, apparently as orthopedic surgeons we have been missing them quite often, and now we're trying to get a real interest into the repair of these lesions. What we see on average on all of these repairs is that it's technically not so easy, and the more complex type of suture you're going to use, for example a modified Allen Mason or a double loop suture, they are superior. But they're never as strong as a native horn. So if you have a top-notch player with a meniscus root tear, that actually we can improve him versus the pre-op injury situation where you can't make him completely normal again. Very important to understand. So that is actually a very tough lesion to treat. Repair techniques are straightforward. You have to identify the lesion. You have to load the meniscus with a suture, you have to create a tibial tunnel, and then you have to fix the lesion. And this is a nice video showing you the situation of a root tear here. This is the horn. You're going to refresh, and you're going to load the horn with different sutures. And so we know that a simple suture will not hold everything, so we need complex sutures. Again, modified Allen Mason, double loops, double interlocking loops. But the space is very small where we're working in. And you need a posterior medial approach. You need maybe a small notchplasty. So this is not very easy and straightforward surgery. So you have to rather take your time and be well technically achievable using arthroscopy. So this is loading the meniscus with a double loop, as you can see here. We're going to drill a tibial tunnel on the anatomical position of the posterior medial root. And then we're going to pick up these sutures and we're going to introduce them. And you can imagine that if your tear is 1 centimeter away from that situation, there's a lot of tension on the root and it becomes really hard to get it actually inside the original situation. So that was the repair. This is a situation, young soccer player, again, rather exceptional situations. You can see, again, the tear of the root, the extrusion, and this is a situation where we were successful in reducing the extrusion, in keeping the meniscus as such, and having a successful repair in this guy 1 year after surgery. Another situation, root tear, which you can see here, older patient, female. For the medial side, most typical situation is that these are somewhat older. And so you have this situation where you can actually load the meniscus with sutures and create a very nice looking repair, but remember, the repair is never as strong as the original meniscus. Lateral meniscus root tears are a little bit easier in a way that very often they heal and there's less stress because you have these other ligaments, the meniscofemoral ligaments, that will actually protect your root a little bit more. So there's less biomechanical consequence if there is a meniscus femoral ligament present. If we look at the outcomes of all of these surgeries, and again you will notice that all of these are very recent data, but this is a scientific output. Long-term outcome of posterior lateral root tears, left in situ, so non-repaired at time of ACL surgery, and this is from Don Shelburne from the US, vast experience. He shows us that they can be left in situ in case of an ACL reconstruction, and actually the clinical results are comparable, but there is more osteoarthritis in these patients 10 years down the line. So you need to be aware that if you have this type of injury, you're going to have more OA. And so this is the issue. We want to protect these patients from subsequent OA, of course, in the long term. It's another very interesting study looking into a meta-analysis of the clinical and radiological outcome of posterior medial root tears. And in this recent study, they clearly showed that the posterior medial meniscus root tear repair is clinically superior, but it does not on average prevent extrusion. It does not on average prevent progression of OA, but it will slow down the progression of OA. So that's very interesting data. So we can, if you have a painful patient and you're gonna do a repair, they're gonna be better after surgery, but we will have still extrusion and the progression of OA will not be stopped, but it will be slowed down. That's very interesting data. So medial meniscus root tears, they have biomechanically a deleterious effect, very important to understand. Lateral root tears are less of a problem because of the meniscus femoral ligaments. If they are present, there's a less of an issue. Medial meniscus root tears, they're more frequently observed as being a degenerative pathology. So most of these patients will already have some issues with that knee or will have a big varus. It can occur, however, in combination with an axial loading trauma or a rotational trauma at a younger age, and this is your typical soccer player. And you have to look always in the varus, which makes, of course, these issues more difficult to treat because the varus will overload that medial compartment even more, especially when the meniscus root is absent. So these are the challenging situations. The lateral root, however, is non-degenerative, is more traumatic, and very often in association with an ACL tear. Medial meniscus root tears, a repair makes sense, and you always have to discuss the options with your patient, but it's not always going to be successful, and this is, I think, what you have to discuss also with your patient. And especially in the football player, the outcome of repair is not clear yet at this point. And therefore, an individual approach is warranted. That means that you have to discuss the pros and cons with these patients, the time he's going to be out of the game, the chances that he's going to return to play, yes or no. So these are all very important things you have to discuss with your patient. On the lateral side, I think repair makes sense, but from the biomechanical point of view, there's less indication if you have an ACL tear. So that's also not clear yet. Anyway, what we need to understand is that meniscus root tears is a potential kiss of death to the knee, and it might be career ending, and this is very important for your professional soccer player, of course. Do not underestimate the power of the meniscus. I will say this in 2016, I said it last year and the year before, so that's very important to understand. And save the meniscus is, I think, the essential piece of information that I want to convey to you. That we want to try to do everything to keep that knee, but it's not always possible, especially not with root tears. Thank you very much for your attention.
Thank you, Peter, for this excellent presentation about this very important topic that for sure we will have a lot of questions to debate. And the debate will be done at the end of this session. And we will move to the second presentation of Peter, that it's what to do when the meniscus has disappeared. So again, a very important problem, non-solved problem, what to do if we don't have a meniscus, especially in high-level players and high-level athletes. Peter?
Okay, I'm back. So root tears are challenging. But this is even more challenging, is what to do when you have lost your meniscus. I think that's a very challenging topic, especially if we're dealing with soccer players. Again, these are my disclosures. So I've told you all about the importance of the function of the meniscus and the fact that, unfortunately, it's difficult to repair. So once in a while, we're going to have to do a meniscectomy, almost in many of these cases. And then sometimes you end up with trouble. So the treatment options for soccer players are generally, you're going to either repair the thing or you're going to resect it. That's essentially what we're doing. And very often, since these guys want to go quickly back to their game, we're going to have a resection in a number of these patients. So let's have a look at the outcome of meniscectomy and the outcome of such a procedure. And if we look at this situation again, there's very interesting data, especially for soccer players. And this is maybe National Football League, which is not a soccer player, of course, but this is US. And it just shows you the data on the situation if you have a meniscectomy, and this is GP means games played. And if you do not have a meniscectomy. And you can see that the effect of a meniscectomy on a professional soccer player, it just shortens your career significantly. If you have an ACL injury and a meniscectomy, and you have an ACL reconstruction and a meniscectomy versus no ACL injury and no meniscectomy, then you're going to see that the group where we have ACL and meniscectomy, those patients have truly a significant reduction in their career. And that is very important to understand. So career is significantly shorted with meniscectomy, and foremost when you have an ACL injury with a meniscectomy. That is really a kiss of death to the knee. Once in a while, we're going to have early complications after meniscectomy. And so the early complications can be swelling. It can be this catastrophic event, which is rapid chondrolysis. And you're going to see a patient coming back into your office 3 months, 6 months down the line after a so-called perfect meniscectomy with some pain and loss of function. This rapid chondrolysis, we've all seen it, and especially again in soccer players, you need to be really careful. It is extremely rare, but watch out. It most often happens after a small partial meniscus tear. And in professional athletes, these guys will come back into your office with swelling, pain after 3 months, after 6 months, so you need to be careful. I think the answer when you see this is slow down your rehab. We always think that medial and lateral meniscectomy are the same animal, and so we're going to treat them the same, but a medial meniscectomy can go quickly back to the game. A lateral meniscectomy, you have to be careful, and you have to watch out for these things, and if there's swelling and pain, slow down your rehab. You can try a cortisone injection, and this is just all recent communication. Sometimes they're going to end up with a repeat arthroscopy in these patients. And again, that may be a career-ending lesion. So a lateral partial meniscectomy, be careful and slow down a little bit when you have issues after that. If you wait long enough after a meniscectomy, you're always going to end up with arthritis in the medial or in the lateral compartment. That's very important to understand. And you do not want to end up with a soccer player that has this as the alternative treatment options. Osteotomies, unis, and totals. And I wasn't here this morning, so I don't know what Philippe Neret told you this morning on osteotomies and soccer players, but I think it's always difficult to convey a soccer player to have an osteotomy and go back to play. I think that's still a very challenging indication. So ideally, you do not want to go and end up in this situation. There's levels of consideration when you're dealing with a post-meniscectomy soccer player. And again, this is a post-meniscectomy soccer player. This is not just you and me. These are soccer players because they have specific issues. First of all, you need to understand the meniscus lesion. And so that lesion is there. It has a specific size. It has a specific location. But you need to be aware that that lesion actually is part of a joint. So you have to look at the cartilage, the status of the ACL, other issues that might happen with that joint. Very important also is that you have to understand that there is actually a leg attached to the joint. It's not just the MRI. There's a patient and that patient has a leg. And that leg may be bow-legged varus or a valgus leg. But look at the alignment because it will very often limit us in our choices and in our treatment options. And of course, there's a patient attached. And allow me, but this is Fellaini, is a Belgian guy, so we're #1 for the moment, so we should be proud. All of these soccer players, of course, they communicate one another, and so very often we're confronted with, I had this and you had that, so there's always a number of things that are in combination, and you need to understand that. If you look at the level 1, the size of the defect or the meniscus issue, then there are small defects and larger defects, and you can have options for the smaller defects, and you're going to have options for the larger defects. And so these are actually very important to understand how big the lesion is that we're dealing with. Also very often is you need to look at the joint on itself, and you need to be aware that there are patients that will come to you with a stable knee and a post-meniscectomy problem. And you're going to have patients that actually have a large meniscus defect in association with a torn ACL. And so that has different approaches because your patient on the left side, the intact ACL, will be out maybe for 4 weeks, 6 weeks, 8 weeks. But the ACL, you have a little bit more time. You have 6 months to a year actually to make things happen and to make things work. So that's a different setup. And also the medial and the lateral side make a difference. If you combine level 1 and level 2, the lesion and the knee joint, then I think if you look at meniscectomies as such, most of these patients do pretty well. Again, lateral side, once in a while you're going to have a patient which does worse. Remember the rapid chondrolysis. In the long term, most of them will end up with some joint degeneration. But actually, if you're a male, you have a medial joint line, so you have a medial meniscectomy and you have normal cartilage, you will do pretty well. It's a different story when your ACL is torn, but we are all aware that you should, in those cases, reconstruct the ACL. If you have a reconstructed ACL and you have a meniscectomy, a majority of these patients, 50% after 10 years, will develop osteoarthritis. And again, shortening the career, be aware of that. If you have no meniscectomy, most of these patients will do well, and most of them will go back to the same level of play. But having the meniscectomy in combination with the ACL actually matters on the short term and on the long term. If you look at the leg situation, and this is the number 8 leg, we need to be aware that most of these patients indeed do have varus alignment. And that is just a matter of fact for the soccer player. We won't see that in a volleyball player or a basketball player, but most of these soccer players will have varus alignment. And that results in medial overload. And that's a situation that we have to accept for a soccer player. And the reason why we have to accept it is that if we look at the patient itself, this option is not really what he would like, because the coordination from the head to the foot changes abruptly, and so that is very hard to cope with being a soccer player. So we all know that, I wrote this, does not work. Again, I don't know what Philip said, but this you want to avoid essentially in these players. And then there's also something very important is what is the player's, his focus point very often. If you look at the situation, there is again what's going around in his head, what does he want? And we have to be aware that most of these guys are really looking for the short-term return to play and very little going to be interested in the long-term goals of preventing OA. So that is something that we had to deal with, is that they want to go back to the soccer game as soon as possible. And the long term is very often of little or less interest to them. And we have to accept that. So again, the treatment options, I discussed the effects of resection in these situations, but now you want me to discuss the replace, which is probably even more difficult or more challenging. So my approach when we're dealing with soccer players and when you do need to operate them, discussing substitution, replacing the meniscus, I think I would only do that when I have a symptomatic patient. That means he comes in with pain and symptoms during the game or after the game. And actually, I would only contemplate doing this type of surgery when he's no longer able to play. And that is something very important to understand. If you have a guy that comes into your office, my first question is, are you still able to play, yes or no? Because if you're able to play, we will try to mediate the situation and manage the situation. If you're unable to play, then I think surgery makes sense. And the reason why is that if you were discussing reconstructive surgery, this will take 6 months to a year. I always tell them at least a year. So this is a big investment with not really guaranteed that they will come back to the same level. And that is something that is very important to understand. So place of biological surgery in this treatment algorithm is if your patient can play, if the patient the player can play, then you're going to go for symptom relief, no big invasive surgery very often. If you have a guy that cannot play, then you want to go maybe for some regenerative approach, meniscus allograft scaffolds. And again, for this osteotomy is not during an active football career. Very often afterwards, but not during an active football career. So again, we lose this option very often. And it makes, however, sense in the varus leg, but we just can't use it that often in our soccer players. Sorry. Going for the treatment choices, medial or a meniscus allograft transplantation, it is indicated in large meniscus defects. And it's all about having the correct indication. If you have the correct indication, you're going to have very often successful surgery. So be careful for these. If you look at the whole concept of meniscus allograft transplantation, this is our data on it. I think meniscus allograft transplantation is successful surgery. And I have to move on. There are a number of indications, mainly subtotal or total meniscectomy, symptomatic patient, stable knee, well aligned. So this is your situation where you can contemplate on having a meniscus allograft. Sometimes you're going to have a soccer player with not just one ACL, but 2 ACLs and maybe 3 ACLs, and then you should think about doing a medial meniscus allograft transplantation in conjunction with an ACL revision. But we're not talking pros, of course, when we're talking this type of situation. And then you have the young soccer player with open physes and a discoid meniscus where the meniscus is lost, and you wonder if you might just provide him a better situation. Very often we're going to have this type of situation. With young arthritic patients, this is the end of career kind of guy that we have in the office. I have done a 10-year career, I torn my ACL, my medial meniscus is out, I want to still play maybe a 1 year or 2 years, can you do something for me? And very often if you look at those MRIs, it's going to be this type of situation. Whatever we say, looking into the data out there, focusing on meniscus allografts and soccer players, if the player is at the end of his career, mat can play a role in averting cartilage degeneration, facilitating knee function, and having an active lifestyle, but focus on end of the career. Is it possible to go back to sports? Yes, it is possible to go back to sports, not always, but the pre-injury level is attained from the Bologna group, 49%, and it takes you about 8 months. And I think from a personal perspective, this is rather quick. We are going a little bit slower in these patients. 36 months, professional soccer players, and this is very, very good data. but I don't think it's realistic for many of our players. 75% in professional soccer players would be able to go back to the same level. Medials go faster than laterals, and some as soon as 6 months. But again, this is really pushing it, and I don't know if this is going to last. Again, for young players, mat is an option, providing pain relief, but not to allow going back to sports according to these. So there is a little bit conflicting evidence in the literature. And if you look at the lateral side, the medial side, we can say that mat provides some chondroprotective effects. So if you want to delay the onset, that is better. For smaller defects, and I'm finishing up here, smaller defects, again, I think indication is key. We have a number of implants, polyurethane collagen scaffolds. This is a typical smaller lesion where you have most of the meniscus intact, but a big defect, but most of it is intact, and the patient is in trouble. He complains of having issues, swelling, and pain in that knee joint. So the concept is clear. You put in an empty scaffold, you put some cells on it, your body grows back, and you're going to end up with more meniscus tissue. That's a concept. It works. It's been well published out there. This is a publication on the ActiveFit. This is the publications on the CMI. But if you look into the indications, again, intact rim, anterior and posterior horn present, partial meniscectomies, ACL should be intact, well aligned. That's very important to understand. And this is a nice video showing you that we can actually fill the hole, and then your tissue will grow back in a number of these patients. However, looking into the sports data, very little data out there. This is the only publication out there really looking into a professional football player, and it's just one case. So this is just a single case out there showing that it can be possible to get these guys back to a professional career, but I guess not all the time. So post-meniscectomy syndrome in soccer players, it is a very complex pathology, and again, very often, it can be a career ending, and we should do the surgery at the end of the career if possible. They do improve the function of the knee, both the allografts and the scaffolds. And the return to play is rather variable, and it takes time, and that is a very important issue with these patients. So best performed at the end of a football career in most of these guys. So thank you very much for your attention.